Hi, I'm Kristen. I'm 5 years out. So for the immunotherapy, the Kaplan-Meier survival curves still don't look great, but you said some people are super responders. At what point do you say to a patient, oh, you're maybe a super responder or you're not doing well, let's take you off? Directly the immunotherapy, because curves aren't great, but some people seem to do really well, even with us.
It seems like a really straightforward question, but so the pithy answer is we would check scans about every 3 months, and you check either an MRI or a CT scan to see if the tumors are growing or shrinking. And if they're growing, particularly if they're growing more than about 20% from their baseline, then we say the drug's not working, we need to take you off. Sometimes in immunotherapies you can get delayed responses, sometimes you can get mixed responses. So immunotherapy has kind of made our jobs of assessing response to treatment a little bit more difficult, but in all honesty, oftentimes it's pretty unambiguous if patients are progressing on therapy.
It seems like there's a dearth of, not dearth, but there's not any clinical trials for a class 2, 4 years out, with no evidence of metastatic disease. It's like kind of a wasteland. Well, there's really nothing to do until metastasis is diagnosed. And I would like to be proactive. Went through one clinical trial I got in the first 6 months with Sutent, cisplatin, and tamoxifen. But is there anything for us to do proactive other than just sit and wait?
That's a good question, Michael, right?
Yes.
Yeah. So most adjuvant therapy, if you take uveal melanoma, even just the disease out of it, you think of breast cancer, skin melanoma, colon cancer, there's a window for prevention to start, prevention therapy, and it varies by disease, but it's typically within the first 12 weeks or 6 months. The reason is if you did a therapy 4 and 5 years later, it's not so clear that it's the intervention that slows down your cancer, or just you have a cancer that's slow to begin with if at that period of time it hasn't come back yet. So for you to have done your 6 months of treatment and be this far out, one would be incredibly optimistic that it's helping you, that it continues to help you. At the moment, the options that you have would not be so much interventional clinical trials, but the laboratory based. So we would love to study your stool. Depending on what they're serving for lunch, maybe we could.
Dr. Patel will meet you
Take some
outside
back
the
to
restaurant.
Texas with you.
I don't have any doggy bags with me when I walk my dog.
I don't travel with them either. But, we would love to study your blood and see if you're somebody in whom we can detect circulating GNAQ, GNA11, circulating tumor cells. What we do with that information for you is a lot more challenging. You would be, participating in more of a group-based long-term outcome study. But it's very difficult, even in breast cancer, 4 years outside of a breast cancer, to find a preventative treatment to jump on. It's difficult in colon cancer. All these cancers, once you're outside kind of that typical prevention window, if your cancer hasn't come back, most people will say, then maybe there's no evidence that you need further prevention. So I'd say, be hopeful, be optimistic that what you did helped.
So come to Houston with some doggy bags, right?
Yeah, we got the doggy bags for you. We got those there.
Hi, my wife she has bad cold, so she couldn't be here. She's 2 years out from enucleation and has been told she has about a 20% chance of recurrence in the first 5 years. Shouldn't she be on a probiotic? Take your pick. Or I'm a psychiatrist, so I feel like I'll put her on Depakote today. But just
Good
thoughts about
questions.
prevention.
Yeah, so 20% risk is considered low, but it's not low if you're the 20%. For you it feels, it feels like you're the one. So again, the problem with Depakote is what dose? A gram, 250 milligrams. It's a hard drug. It has effects on your platelets. It makes you feel like you're constantly sedated or drunk, if you will. Our leukemia doctors who did a Depakote trial said it was like having a waiting room full of drunks at one point, you know?
I prescribe a lot of it, so I've seen all of that.
You know.
Some people have a lot, and gain 40 pounds, and some people have none.
Yeah, and so do you tailor it to side effects, or do you tailor it to scientific dosing on what it's doing on your peripheral blood white cells? Ideally, you want to know what it's doing on the tumor cell, but there's none to capture, right, in the prevention stage. Probiotic is controversial. You know, if you look at some of the studies and what bacteria is doing in the gut, there could be probiotics that you take that actually give you a lower immune response. So until we know more, it's hard for us to say, yeah, you should be taking a probiotic for good measure, because what if it contains the wrong balance of bacteria and actually lowers your ability to do immunity? So the goal of the whole microbiome research is actually to figure out what the right balance is, and then make that probiotic and, you know, sort of say, this is the probiotic if you're a cancer patient needing to boost your immune therapy or your immune response.
So I'm assuming there's work being done on that,
There is.
researching the biome.
Yep, there sure is, yeah.
Clinical trials are a huge issue, I think, for this population. And it's really frustrating to me that it's difficult to get into them, I think, for a multitude of reasons. But I'm wondering if the excess of caution is because the FDA says it must be like that. Because we're dealing with a population that has very small numbers. We're dealing with a population that tends not to stay around very long. So if you're going to experiment, you need to hurry up and do so. And when I look at the list of exclusions for clinical trials, it's always exactly the same. And I just keep asking myself, should that be there? Should that be there? Should that be there?
Yeah, that's a great question. One of the more frustrating things that we can do as providers is have a patient who seems to be a great candidate for a clinical trial, and there's oftentimes a long list of exclusion and inclusion criteria, and it's something that we as clinical researchers have to take a very careful look at and say, well, you know, in opening this trial, do we really need to have, you know, platelets at this particular level, or, you know, LFTs at this particular level? And, you know, it's difficult because you want to make sure that you're making an apples to apples comparison in your study, so that when you get to the end of it, you don't realize, oh, well, shoot, you know, there was this confounding aspect of this population that means that that's why we saw this effect or didn't see this effect. But it's kind of as much as we like to think that it's a science, there's also some art to designing these trials so that they will answer the question that we want them to answer in a time frame that's reasonable, in a clinically meaningful way. So, but I agree with you. I think that oftentimes our clinical trials, it seems like we just keep adding more and more exclusion criteria without taking a critical view of what exactly are we trying to answer here, and what do we need to do that.
So, you know, a lot of these exclusions are there for a reason, and you're right to ask the question why they're there. Each hospital's institutional review board and even group institutional review boards look very carefully at these things. But most importantly, the FDA looks at it. And so we have some industry partners in the room, they can speak to this. If you have a trial with really essentially no restrictions, and the first patient goes on and dies, even if they die from their disease, that can put the entire process on hold until the FDA does a deep review. And the FDA is not a rapid turnaround. You give them your submission, a patient has died, they take 30 days to give you an answer. And typically they answer on day 29, that's my experience. And I understand why. And then they have more questions. So then you address those questions, and then they have 30 more days to give you their response about whether you're still on hold, whether you're open. And so, you know, sponsors have become really careful. They can't enroll somebody with, you know, wildly comorbid heart failure or wildly out of control COPD, and it's a drug that has some pulmonary issues with it. So the restrictions are typically there for a reason, and it's very reasonable for you to ask your team, you know, why does it have this liver restriction? Why does it have this autoimmune restriction? And they should be able to at least explain it to you. It is difficult to find a medical oncology trial that doesn't have an exclusion list of at least a half dozen or a dozen points for that reason. And a lot of that is driven out of an abundance of safety. The end result is you end up finishing a clinical trial that looks different than the real world population. And that we know. And that is being scrutinized in many different areas in oncology. Some of our leukemia colleagues are doing a trial for patients who are historically not eligible for trials. So our clinical trials will say you have to have this kidney function because of drug metabolism issues, everything. So they are running a trial saying, if you don't have a good kidney function, get on the study. The FDA is aware we're looking at in a different population, but that's certainly more reflective of the real world.
And if I could just add one thing to that, just in terms of the recruitment, I think this is something that's come up many, many years over at our scientific meetings. And there's been a lot of discussion in the research community. How do we prioritize research and how do we prioritize clinical trials? And can we build consensus within one country, globally, of how we'd want to prioritize clinical trials to enroll in certain ones to get answers faster? And it's actually something that a number of advocacy organizations are coming together on. And so our next scientific meeting will be in partnership with the Society for Melanoma Research Congress in October of 2018 in Manchester, UK. And we've come together with some other advocacy organizations who actually want to ask that very question. Can we develop some consensus about a blueprint for research in clinical trials to really address the patient enrollment piece? And I'm not, we haven't had total consensus on that, but a lot of people really want that. And so are we at a place where we really have, the collaboration, as we were talking about earlier, amongst colleagues, and we have the push to be able to make that happen?
I'd just like to add to that. I think the patient advocacy portion and working through organizations like this is critically important. The FDA, when they first reviewed the percutaneous hepatic perfusion treatment back in 2012 or so, this was the first and remains one of our only treatments that has evidence that it can keep disease controlled in the liver for 7 months, or a median time of 7 months. If you look at all of our other treatments, they haven't controlled it for as long. The FDA looked at that trial and said, there's a death rate in this procedure. It's essentially open bypass procedure for the liver. So if you know about cardiac bypass surgery, it's bypass for the liver. This was percutaneous, so not open, but essentially the same sort of concept. And the FDA looked at that and said the death rate associated with this study, and I don't know the exact one, but it's 10% or 5% or something like that. They felt that mortality associated with the procedure itself was too high. Now, you guys know there's a death rate associated with cesarean section, getting your appendix out, your gallbladder out. We want those to be as low as possible, but there's a death rate. What seemed very short-sighted from the FDA's perspective there was these were patients with metastatic uveal melanoma. We think that's 100% fatal if they're not treated. So if there's a procedure that has a 10% mortality that goes with it, we don't like that either. But it makes no sense that they didn't understand, that patients understand that risk, and they understand it's a little bit of, there's a risk with this procedure, but if it can extend my survival, I have something that's universally bad news. So they don't seem to hear that message. So the more that I think, the patient advocacy groups can come up with these statements on behalf of their members saying, listen, we don't want placebo-controlled trials. We don't want placebo-controlled adjuvants. We understand there's a 10% procedural mortality rate or morbidity rate with this, treatment, but we have a disease that is universally bad. So that risk we're willing to balance. So I think that voice, they need to hear that patient voice a little bit more. It's just they don't seem to be listening to the companies, and they don't necessarily seem to be listening to the providers.
So kind of a different direction for a question, and it may be more appropriate for a different speaker, so if that's the case, we can ask it again later. But from a research perspective, what are the thoughts on late-stage metastatic disease? So for example, the Kaplan-Meier graphs show very significant decreases in the mortality rate of patients, but in the community, we see a lot of patients that go many, many, many years without metastatic disease, and then there's an onset of metastatic disease. So is there any research in either one of your clinical settings that's being done in terms of late-stage metastatic disease opposed to adjuvant therapy before metastatic disease even is on onset?
So I'll just answer briefly. I think this is a great question for Dr. Woodman, who's giving a talk in the afternoon. He has some data and he's done a lot of work on the timing of metastasis, the outcomes of people who metastasize early rather than late. There's different characteristics of those tumors. So not only do we want to study those patients, we may also want to profile tumors earlier so we can start to really, class 1, class 2 is useful. I think it is useful, but I think there's even more stratification you could do. You're a class 2, you still have the question, is it coming soon or is it coming later? And so I think there's a lot that can be learned from that, but Dr. Woodman is our expert on timing of metastasis.
I think this will be our last question before lunch.
My name is Carla, and I was initially diagnosed in 2004 and metastatic disease to the liver in 2013. And then in 2016, a lymph node. I had a FNA, and that was confirmed metastatic. And then a year ago, I was confirmed with brain mets and had a craniotomy at the University of Colorado. So do you think, because it's so rare, everybody says, well, that's really odd, that doesn't happen. But do you think it's because patients are living, I responded obviously to radioembolization on my liver. Do you think maybe it's just because I'm a responder, I treat each thing as it happens, and because I do have brain mets, but so far I'm now on Keytruda, and think my brain mets are stable, and the lymph node has shrunk by 50%. So I'm kind of feeling like a zebra with two heads, but just a rare case.
Well, first of all, that's great. I'm very happy to hear that you've had such a great response to all of those therapies and that the tumors are shrinking on Keytruda. And I think that your presumption is correct, that for patients who sort of defy the norms in terms of how the disease progresses and how it responds and so forth, we're really bad at taking general population level statistics and applying them to an individual patient, because kind of once you're in the realm of zebras, every zebra is different and kind of all bets are off there. But if you take on a population level basis, you are 2 standard deviations outside the norm in a good way.
Okay, now last question over here.
Dr. Patel, you mentioned a reason for a lot of the clinical trials being canceled was slow enrollment, and I understand inclusion, exclusion, time out from treatment or diagnosis, I understand that. Are there other contributing factors, and is there anything that we can do about that?
It's hard. You guys all know there's only a handful of places that run these trials. And then, like a vaccine schedule, you may have to come weekly for 6 months. Or what's the other one that closed early? The radiation one. Once you start looking at, oh gosh, I have to be there for 2 weeks continuously. So a lot of times it's the schedule that's hard, and we try to minimize where we can the excessive blood draws and all that kind of stuff. A lot of the phase 1 drugs, you have to have your blood drawn 3 or 4 times in the first 24-hour period. You're sitting there coming back to that lab to get it drawn as you take the medicine an hour after, 4 hours after, 12 and 24. It's a lot to ask. And it sounds okay when you're kind of first maybe starting, but then the dropout happens. Or, patients go home and read about it with their family and they think, well, we can't come that often. So I think it's accessibility. These trials are not everywhere. They're often at just a few scattered places. The schedule is difficult. The inclusion-exclusion criteria is difficult. And, I think we always enroll better on the metastatic side than we do the adjuvant side. The adjuvant side typically is where the stuff is terminated. I think we have to do better. We have to design the trial that you guys want to be on. you know? So if you have thoughts of what actually would stop you from doing a trial for a year of prevention, let us know. If it means there's no way you can come weekly for 6 months, let us know, and we'll do what we can to avoid designing trials like that, you know?